Mental health is striking a balance, is a learning process, and is unique to the person. Here are a few other definitions I just want to keep uh, in your minds. First one is chronic conditions. Chronic condition is specifically defined as a condition that impacts the life of an affected person for an extended period of time and cannot be cured. Psychosocial and neuropsychiatric are very intertwined words, but they do mean different things. Psychosocial is specifically the influence of psychological factors and social environment on the well-being, mental health as well as biological. Neuropsychiatric, on the other hand, is mental health issues that relate to the nervous system. So there's actually something in error in the nervous system that causes these issues. Etiology is basically a fancy word for saying the cause of or reason for a disease or condition. Many these words may be familiar to you already, but just in case, I'll provide a definition. Now, mental health is very prevalent in general. In Canada, 20% of the Canadian population experiences a mental health issue every year. By the age of 40, 50% of the population would have experienced at least one mental health issue or event or something. Unfortunately, 70% that have chronic mental health issues, they start off in childhood and adolescence. Mental health issues also are the leading cause of disability and have a significant mortality associated with them. Here's a bunch of figures from 2012. Unfortunately, more recent numbers are not available, at least when I tried looking, but it gives you a brief overview of how much of an impact mental health issues can have, especially in the younger population. This doesn't mean that it doesn't impact the older population as well. It's just to show that it is a leading cause of death in these age groups noted. So, what causes mental health issues? Well, very early, mental health issues were blamed on demonic possession and supernatural forces. Some East Asian cultures consider them imbalance of positive and negative, balance leading to proper mental health, and imbalance leading to issues. This evolved over many centuries. There were some many other definitions, such as by the Greek and so on and so forth, but majority of the modern definitions were started to be formulated around just before World War II, such as by Freud, who blamed everything on childhood trauma. Watson, who, on the other hand, argued that no, it's behavioral conditioning, which basically means that it's a learned behavior that a person repeats over and over again due to a trigger. This further evolved after World War II, where this really long book, this really long titled book was created by many leading medical physicians and such to outline what can cause disorders, describe them, and provide a way to actually diagnose them appropriately. Early editions were mainly stating that the etiology of mental health issues is due to factors that a person reacts to. This quickly evolved by the third edition to remove any kind of etiology questions and descriptions and just remain neutral. Because the honest answer to the question, what causes mental health issues, is we don't know, or at least it's not very clear. These are some things that can cause mental health disorders. Biological impact, such as genetics, hormones, and actual structural changes, whether it be in the brain, the nervous system, or others. Because the endocrine system, which is your hormones, can also impact that as well. So if you have a thyroid issue, environmental factors such as expectations, stigma, or even an injury can cause mental health issues. And finally, the person themselves. If they don't learn or know good coping skills, if their interactions cause stress and anxiety, as well as their behaviors, these all can also compound the effect and cause issues. Now, specifically for Fabry disease, the biological impact is literally the disease itself. The environmental impact can be the burden of the disease, social factors associated with having the condition, as well as the unclear future, which can also fit into the personal side. Same with burden and disease and coping problems. Some people are okay with having a diagnosis, other people are not. Some people are okay with telling other people that they have it and actually getting treatment. Some people may not be. All of these interact together and may lead to a mental health issue. Now, during this presentation, I'm going to concentrate a little bit more on depression and anxiety. It will become clear later on why, but this slide is to show how mental health can impact the three factors outlined as well. Having depression and anxiety is documented to reduce treatment response, so you actually do worse or don't do as well as you should while on treatment. It decreases compliance, which again interacts with the treatment response, and can actually increase the self-perceived severity of symptoms or even quantifiable severity of symptoms. That's the biological and medical side of things. On the personal side, mental health issues are documented to cause a significant decrease in quality of life, a significant decrease in social relationships that affected individual can have, and related to that, decrease in activity levels. As you may have noticed, a lot of these things interact with each other. Having decreased activity levels can lead to worsening quality of life as well as worsening symptoms. Decreased compliance, same thing. If you don't have social relationships, you might have a decreased quality of life, so on and so forth. This is why we would like to identify issues early and help address them before they compound other issues and make them worse. So now let's get into Fabry disease. I am going to warn you guys right now. I'm going to go quickly through these slides. The question and answer is at the end, but I'm hoping that there'll be more of a discussion than content for this time. As everybody is well aware, Fabry disease is a rare genetic disorder that is chronic and progressive and impacts multiple systems. All of these bolded words are very important in the context of mental health. How so? Rarity and being a genetic condition leads to these issues. First of all, lack of knowledge. I am pretty sure everybody can relate to the fact that they've gone to an emergency room or seen a new specialist or another doctor who had no knowledge of what Fabry disease is. That's concerning. It leads to lack of faith in the healthcare system. It can lead to decreased faith in actually listening to a person who's giving you advice that may be applicable if they don't know what you even have. Lack of knowledge also is prevalent in patients, as well as their social circles. Leading from the social circles, a rarity and genetic conditions tend to have a lack of support. Luckily for Fabry disease, as evidenced by tonight, we have an amazing Canadian Fabry Diseases Association, which has developed into a really effective patient support program. Considering when I first started, it wasn't as much. Now, I'm not going to downplay anything back then. It's just that the evolution has gone through over the last few years is honestly amazing. Also, in the social circles, a sense of normalcy due to having a rare genetic condition is lacking. If you can't be related to, such as if you have a broken bone, somebody else might have a broken bone and they can relate to the fact that you can't move it or it hurts. But having Fabry disease or any other genetic condition, that is a lot less common. In fact, completely rare. Unfortunately, genetic conditions tend to also cause a lot of guilt. They tend to lead to a lot of hopelessness and frustration. Let's move on to the next one. These are all part of the environmental and personal impact. Chronic and progressive. Chronic conditions, especially when they're progressive, lead to a lot of uncertainty about the future. When will I live till? When will I be able to do things again? Or when will I have to stop doing things? When do I tell people? When do I not tell people? So on and so forth. Same with the rare and genetic part. Fitting in tends to be harder simply because you're limited in what you can do, or you might be told that you're limited. And finally, chronic and progressive conditions lead to a significant amount of financial strain. Uh, Fortunately, in Canada, the social healthcare system does help address some aspects which may be experienced by people around the world, such as having to pay for treatments if you don't have insurance, there's no public reimbursement, or even just seeing a specialist that will diagnose you with the condition. That being said, it doesn't mean that there isn't any financial strain. Having to come to appointments means that you have to pay for gas or a cab or some kind of transport. If you can't work because you're on dialysis, how are you going to earn money? Disability may help, but sometimes it's just not enough, so on and so forth. This, again, is environmental and personal impact. Finally, the big one. The multi-system portion of Fabry disease can significantly impact the mental health of a patient. These are numbers specifically for patients who have just that system issue. So if a patient has cardiovascular issues, not in Fabry disease, just in general, such as if somebody had a heart attack, they would be considered this group. It's already proven that they will have higher rates of anxiety. 20 to 30% of the population of cardiovascular patients would have some kind of anxiety. 31 to 45% will have depression. Now, just to put it into context, in the first slide, I said 20% of people in Canada experience some kind of mental health issue. Depression rates are similar to that. They range from 15 to 20. Anxiety is closer to 10 to 15. So you can already see that these figures are 2 to 3 times higher. As expected, quality of life is significantly decreased as well. Now, for the renal population, depression rates tends to be even higher, at least what's been reported in literature, as high as 65%. Decreased quality of life is well documented. Also, decreased levels of activity and perceived health. This is very important. You might be aware of the concept of self-esteem, and it is strongly intertwined with mental health simply because if you feel like you're not good enough or if you're not healthy enough, you won't be. So decreased perceived health is just as bad as having a broken bone, just as bad as going into renal failure, simply because it may actually cause those issues as well. Now, I say may because all of those issues that I outline will have a biological cause as well. It's just that the rate of decline may be increased simply because you are depressed, you do feel that you're sicker, therefore your body becomes sicker. For neurological patients, post-stroke, depression and anxiety are increased. Pain patients also have increase in depression and anxiety. This is why previously I covered I focused on depression and anxiety simply because these are two mental health issues that are very prevalent in the systems that are impacted by Fabry disease. The last one there is not really well studied, but there are a couple of papers that specifically talk about angiokeratomas. Angiokeratoma, if you are not aware, are the red spots that Fabry patients can get. They can appear anywhere. Some patients may just have one or two, other patients may be covered in them. A paper asked patients how they feel about them. And unsurprisingly, a lot of patients came back, especially younger ones, saying that they're embarrassed, that it makes them hesitate to become close to others simply because they don't know how others may perceive them. So while it's not studied, it may be another factor that impacts self-perceived health as well as rates of depression and anxiety in patients with Fabry disease. Now, this is other diseases. These are papers written by other people, specifically looking at other diseases. What about in Fabry disease? Uh, I'm going to go into a study that Dr. Morel, Dr. Fabry, Dr. Joyce So, myself, and a few other people at the Toronto Clinic did with the aims of establishing how common are mental health diagnoses in Fabry patients, as well as how do those mental health diagnoses relate to severity or presentation of Fabry disease symptoms. The results were unfortunately not surprising, simply because the rates of mental health issues in our population were a lot higher than the normal population. 60% of our patients had some kind of mental health diagnosis at some point in their life. 30% had depression, 20% had anxiety. So compared to general population rates, that's 2 times the rate of depression and again, 2 times the rate of anxiety. In addition, we found that if you had neuropathic pain, you were 3.9 times more likely to have depression, 3 times more likely to have anxiety, 6 times more likely to have any other kind of mood disorder, which includes a wide spread of mood disorders, hence why it is such a higher likelihood. But that one you can disregard for this part simply because the number is inflated due to the widespreadness. Diarrhea, a very common Fabry symptom, is also associated with more likely of having a mental health issue. 2.4 times more likely depression, 5.1 more likely to have anxiety. As you can see, this is already concerning even though we're not even looking at cardiac presentation, whether they're on dialysis, how far is their renal disease, so on and so forth. We also found that, as expected, patients with a mental health diagnosis, this is including depression patients, anxiety patients, and generally just any kind of diagnosis, had significantly higher pain scores, as well as significantly lower quality of life scores. So we basically did prove that our study population does have higher rates of mental health diagnoses, and there's a strong association between GI issues, pain issues, and having a mental health diagnosis. There's a star there. The reason for that is we cannot say with any conclusive confirmation whether or not GI and pain came first before the mental health issue, or did the mental health issue come and then made the GI and pain worse. This is just establishing that there is a relationship and that it should be looked into. And fortunately, a lot of people have. Since this paper, at least five other literature papers have been published, with the most recent one actually using psychiatry methods in order to confirm diagnoses rather than just look at charts and see if anybody mentions that this patient has a diagnosis. Those kind of studies are very useful simply because they're standardized, meaning that if a psychiatrist evaluates a patient and says that they have depression, it means a lot more than a simple note that says, hey, this patient may be depressed. So it's a good thing that people are looking into this issue. Now, why did I bother explain what neuropsychiatric means? The reason for that is literature has time and time again stated that in Fabry patients, cognitive functioning can be impaired or lower than the normal population. What does that even mean? Cognitive functioning is how a person thinks, their thought processes, and how they react to things. Especially for Fabry disease, they found that executive functioning, which is taking in thoughts and then processing them, was impaired somewhat compared to a general population. Now, again, there's no indication in any of these papers which came first. Did patients have neurological symptoms which may have caused these issues, or were these already present prior to having a stroke or white matter changes? So right now, it's not something to panic over or anything. It's just something to keep in mind. Overall, there are psychosocial and neuropsychiatric issues present in Fabry disease, as well as social adaptive functioning, which is basically how a person adapts to the social environment, makes friends, gets along with people, so on and so forth. And we should be addressing that. So how do we address each part of these? Rarity, that's an easy one. We're doing it right now. The Canadian Fabry Disease and Canadian Fabry Association has been amazing with their awareness campaigns. Not only that, the amount of brochures, information packages, as well as just being a resource for patients to contact and for healthcare providers to contact just to get knowledge, they're amazing. So that's being addressed in some manners. Now, I will also acknowledge the various pharmaceutical companies involved in this whole disease. So Shire, Genzyme, and so on and so forth. They have also contributed a lot to these awareness campaigns, and their role should be acknowledged and thanked for. Now, chronic and progressive part is a little bit harder. Unfortunately, a lot of Fabry disease symptoms should be managed by specialists of that uh, specialty. Sorry. So cardiovascular issues should be managed by a cardiologist with a geneticist involved to oversee and guide resources. So chronic and progressive nature depends on the symptoms you have, and you should utilize resources that are available from the specialty that looks after the symptoms you are experiencing. Similarly, with the multi-system, understand limitations. I've had people come in and ask me, hey, I've been put on a no salt diet. My food tastes like crap. Pardon my language. It will, but that doesn't mean that it has to stay tasting like crap. And hopefully after this presentation, Julia can answer this question. I know that for Fabry disease, they're working on a diet brochure or information package that will include some recipes as well. Our dietitian in our clinic was kind enough to actually make some of them, and they do taste amazing. And supposedly they're very healthy as well. So things like that, you need to understand your limitations instead of just accepting them. Unfortunately, the last one, the genetic nature of the condition, which can cause burden on not only females, males as well, but historically, due to their carrier status, it led to more of a burden on females. Uh, Leads to a lot of guilt and frustration. It leads to a lot of indecision and uncertainty regarding future, whether to have children, whether not to have children, what to do, how to evaluate it, when to tell people. That is an aspect that you should contact your genetic counselor and so on and so forth and discuss with them, as it needs to be adapted individually. So, how do we actually diagnose a mental health condition? First step is actually identifying that there might be a concern. The quality of life questionnaires that we make you do at every visit, I know they're long, I know they're boring, and I know they're the same questions over and over again, but we do review them. We do track them. In fact, I have charts of every single patient historically looking at how they rated their own quality of life, how it changed, so on and so forth. If we do see a dip, we do become concerned. If there's a reason for the dip, that's good. But unfortunately, if there isn't any apparent reason, we will reach out to the patients to ask them. There are condition specific assessments, such as the Beck Depression Inventory, which only looks at how a person rates themselves on a depression scale. And finally, the big one is self identified changes or trends in your own health, your own mood, and your own daily living. If you notice yourself being depressed in the sense that you are not getting happy with things that used to make you happy, if you are becoming more secluded from your friends, your social circles, so on and so forth, or as simple as you don't want to go into work, even though there's no reason not to go in, those are signs that should be evaluated. Diagnosis itself is a little bit more complicated. Luckily, most family physicians are well versed in common tools to diagnose straightforward mental health issues such as anxiety, ADHD, depression, so on and so forth, by reviewing symptoms with you, going over them, seeing how they change, so on and so forth. But for more complex conditions or actually getting a psychiatric evaluation requires a structured interview. Now, if you consider the three questionnaires that we do at Toronto long and boring, a structured interview can last up to 3 hours. You sit in a room with a one person who will be asking you questions over and over again, trying to identify, diagnose anything that you might have. It's not very pleasant. I actually had to go through training for it. I actually had to sit through people doing it on me. Now, as unpleasant as it is one of the best methods to diagnose these things. Unfortunately, it's not very feasible. After you've been diagnosed, what do you do? Uh, Mental health issues, especially depression, anxiety, the treatment is very individual specific. What works for one person may not work for another. There are pharmaceutical interventions such as SSRIs, SNRIs, or medication names such as Zoloft, Lyrica, so on and so forth. Luckily or fortunately, some of these medications that are used for antidepressant purposes can also be used to control neuropathic pain that Fabry patients experience. So luckily, it ends up being a dual function. Now, those tend to be frontline interventions. They're not a cure-all. Generally, the next step, or generally together with pharmaceutical intervention, psychotherapy is recommended. This can include cognitive behavioral therapy, where a person would talk things through with you and help you identify cues in order to stop depressive thoughts or anxious thoughts from taking over. Interpersonal therapy is similar. just without the behavioral modification associated with it. If none of the above work, there are other options. Electric shock therapy actually is an effective measure that's being studied and used lately. So if the above two don't work, it doesn't mean it's the end of the road. It is something that you should be discussing. If you are on a medication for depression and it's not working, please let your prescriber know. Please discuss with them alternatives. There may be something else that you can try. Now, problem with diagnosis and treatment is a person actually has to seek out help. Unfortunately, with mental health, there's a very strong stigma associated with it. The top two quotes are from a study in UK where people indicated that people with mental health issues, this is as mild as depression to full on severe psychosis, were all considered dangerous. The UK population unfortunately also considered mental health issues to be self-inflicted, both of which are untrue statements. You might be thinking, hey, Canada can't be that bad. Unfortunately, a 2008 survey in Alberta found similar results. So what can we do? Luckily, both of those papers are very old. Uh, since then, at least in the last 10 years, there's been a lot of anti-stigma programs. The more obvious or prevalent one being Bell Talk or Mental Health Day in February. In addition, improving understanding and knowledge of mental health goes a long way. If people know that, well, uh, patients with depression are not dangerous, they're not going to harm anybody or themselves if they have appropriate care, they tend not to say things like that. In addition, resources to actually identify stigma, because sometimes stigma may be invisible to the people inflicting it, are very prevalent nowadays as well. The big one being through CAMH. It's called Understanding Stigma. I believe it's a course that anybody can access. Uh, I will double check, and if you are interested in it, I can send you a link. My email address is at the end of this presentation, and it might be a good resource just to read through and see. Now, why should we address stigma? One, it improves self-esteem of patients. Uh, it improves acceptance. It gives them a sense of normalcy. And it also helps remove barriers that may be present from them actually getting help that they need. Now, before I end this talk, I do want to talk about one more aspect of Fabry disease, the caregiver. Caregivers, on average, provide 20 hours a week providing care. 20% of the caregiver population, sorry, this is in the US, give up almost 40 hours a week providing care to a person with some kind of chronic illness. That's a full-time job. Due to that, they are at risk for depression and anxiety. It's proven that they have a greater risk of mortality, 63% increased risk of death. And they have a significant amount of stress. It's not easy watching people that you love suffer and not being able to help or even at times relate. In addition, similar concerns such as financial stress, relationship stress, having to argue, hey, should you go see a doctor about this? Should you go see a doctor about that? Balancing needs. If there are other family members that are not affected, they have to balance the needs of them as well as the person who is. And when it ends up being lack of cooperation between the family members, it leads to a significant amount of stress for the caregiver as well. So they may not have the disease, but it does strongly impact them as well. What can you do? Encourage self-care, self-health. Ask them when's the last time they went to see their family physician. Get information on supports available for caregivers. Get information on the condition itself to help answer questions that lead to arguments or disagreements and so on and so forth. Easiest ways is contact the clinic that you're being seen at and ask them questions. I know for a fact Toronto is more than happy to answer any questions that anybody in our patient population raises. Now, I don't recommend everybody send us questions simply because local physicians who have been following you for a long time will be able to provide more accurate information in regards to yourself. And finally, allow them some time to themselves. It is very important. They need a break as much as anybody. So caregivers are part of the care team just as much as everybody else a patient may see. So in conclusion, mental health issues are strongly associated with chronic conditions, including Fabry disease, can be due to multiple factors, and their impact can be multifaceted as well. Unfortunately, they can also compound existing symptoms, worsening them, making them feel like they're worse, so on and so forth. And they impact everybody just as much as they impact the patient themselves. Thank you very much. I hope that was useful.
Thank you, Syed. That was wonderful. You never do disappoint. You always do such a good job and very factual. I really like that you touched on caregivers and them being part of the care team as well. I think that's really important and nice for all of us to see. So does anybody have any questions? While I wait for them to come in, you did mention the brochure about the diet. So we are working on something right now with one of our industry partners. It's called Nourish. And Nourish is a little booklet that kind of focuses on things that are helpful to the Fabry diet. It was touched on that there's a diet called FODMAP, so FODMAP. That's something that they're looking into. There is some evidence, and they're just kind of learning more about that diet with Fabry patients, and as well as our new board member, Dr. Seema Conwell. She participated in the Nourish book as well, and so she suggested some recipes, some things that can help with some of the issues of Fabry disease, including depression and anxiety, and some of those foods that can they're kind of known as happy foods, and so that will be out, I think, in 2019, probably early 2019. So we do look forward to sharing that with everybody. I just got a question here, just a private question. Someone just asked, Syed, if you know anything more about the FODMAP diet as far as where we're at with that.
Yes, we do, and no, we don't. Is probably the best way of approaching this. We, in Toronto at least, we have trialed it in a few patients. Unfortunately, there isn't much uh, results available overall regarding FODMAP in Fabry patients. Our patients that did trial it did find some use of it, but due to the fact that it's a very involved diet, it isn't as simple as just cutting out one food, not eating this, not eating that. It's actually cutting out a lot of things and slowly introducing back things that may be okay. So it doesn't happen overnight. It does require a lot of compliance. And if you are complaining about a no salt diet, the FODMAP diet won't be for you. But we're hoping that if you can follow through all the instructions that a dietitian will give you, it theoretically should improve GI symptoms as well as energy levels, because that's what it's been shown to do in other conditions such as IBS, which mimics Fabry disease's gastrointestinal symptoms as well. But unfortunately, right now, we just don't have enough evidence to say, yes, it will work, or no, it doesn't.
Thank you. It seems like the questions that are actually coming in just to me. I think it doesn't seem that they're coming in to everyone. But we have a couple people that said, great job. Thank you, very informative. And thank you for touching on the neuropathic pain as well as, neuropathic pain as well as how being on an antidepressant can help, kind of a double, how it helps both ways, I guess. So that's someone, so thank you for that, for explaining that. We have one here from, do you have any recommendation to improve perceived health?
Sorry, improve?
Yep. Do you have any recommendation to improve perceived health?
Unfortunately, no. I am not knowledgeable enough to be able to provide resources regarding that. That being said, it's a very good question, and it is something I'm going to actually look into immediately after this. I'm hoping that the next presenter, who will be a colleague, Sandra Tavares, will actually be able to provide more resources on that, as she will be approaching this from a social worker perspective. Is that correct?
Yes. Yeah.
So,
Yeah. And she's going to be on in January, I believe. Yeah.
I will relay to her that you raised this question and that she should cover it. Is that good enough?
Yeah. Yeah, thank you for that. And so, yeah, if we want further information on that, the webinar in January will be great. Janice says, thank you very much. Yes. Donna says, great job, Syed.
Thank you, Donna.
And I think that's it for our questions so far. I think I got to all of them. Lots of positive feedback, Syed. Thank you so much. I appreciate you and your time and everything you do for the CFA. You're a part of that team as well, so thank you so much.
Thank you, Julia, for having me. Thank you, everybody. Have a great night.
Okay, have a great night, everybody. Thank you very much. And our next webinar will be in January 2019, so happy holidays. Take care.